So the topic is on insulin resistance.
Okay.
It's a very simple topic.
Okay.
So
okay,
what
okay,
are the
right.
medications and lifestyle changes? How does it address insulin resistance? That's what I'm going to make it simple. So good morning to all. Thanks to GVK sir and the team for the opportunity given. The topic is a very important topic. So insulin resistance. So every time it is talked about insulin resistance, definitely there will be a significant component of insulin resistance in most of the diabetics, especially if it is a type 1 or a few diabetes, where insulin resistance component is not significant. So what we are going to discuss today is, how do you move the slide? Only pointer is there. So, okay, I will move here. So first we should know the basics of insulin. So what is insulin resistance? What are the components of insulin resistance? So where all you should target insulin resistance. If you know the basics of insulin resistance, so these are the components, and how do various molecules, whether they target most of the components of insulin resistance or it is restricted to a few components of insulin resistance. So what are the components? The first one is lipid overload, we all know. From muscle, liver and fat, there is excess fatty acids, free fatty acids, diacylglycerols and ceramides. These are the toxic lipid molecules. So this is one of the significant contributors to insulin resistance. The next one is a molecule that is these lipids, when they are excess, that is diacylglycerols and ceramides, they activate PKC, protein kinase C isoforms, which interfere with insulin receptor signaling, preventing insulin receptor sensitivity, that is PI3 kinase pathway, from working properly. From lipids, there is a signal disruption. The third one is GLT4 impairment. So this disruption reduces the movements of GLT4 to the cell surface, blocking glucose from entering the cell. Third component. Fourth component is mitochondrial stress. 4 and 5 is universal in most of the patients. In the present scenario of sedentary lifestyle, stressful lifestyle, all make the stress of mitochondria and ER stress significant. So what does it do is, again, FFA raises intramyocardial mitochondrial ratios of acetyl-CoA to CoA, NADH to NAD+, inhibiting key enzymes like pyruvate dehydrogenase, leading to citrate buildup, which slows glycolysis. This is mitochondrial stress. What is ER stress and inflammation? Definitely. What happens is misfolded proteins, accumulation of misfolded proteins, trigger the unfolded protein response in the endoplasmic reticulum, activating inflammatory pathways like Janus kinase, JNK, that further block insulin signal. We will be addressing what are the various molecules in practice, whether they address all the components or what are the specific components being addressed with each molecule. That's what we are going to discuss. So before that, what we discussed is in the picture. Most important we put as a adipose tissue. This is adipose tissue. Increased glucose metabolism, increased lipogenesis, decreased lipolysis. This is a normal physiology. In an increased component of insulin resistance or when a diabetic, this lipolysis is increased. Decreased glucose synthesis, glycogen synthesis, increased glycogen synthesis, increased lipid accumulation, increased inflammation occurs because of increased insulin resistance. This M1 macrophage is a good macrophage. If there is a insulin resistance and inflammation, there is conversion of M1 to more of M2 macrophages, so inflammation is worsened. Because of this, there is a cascade, increased hunger, decreased hepatic glucose. I am not going to the details. Increased glucose metabolism, increased glycogen synthesis, increased muscle mass, increased mitochondrial dysfunction. So everywhere there is liver, pancreas, peripheral muscles, brain, everywhere it is targeted. That's what is the picture. What does this picture say is, what adds to is, there is a overnutrition and sedentary lifestyle again adds to the complex physiology. So this picture will come again at the end of the session, which says what are the molecules where all it is targeted, starting from skeletal muscle, liver, and what happens with increased hypersecretion of insulin in the liver. There is a component of hepatic insulin resistance, peripheral insulin resistance and hepatic insulin resistance contributing to, we are seeing a lot of MASLDs now. So we should target MASLDs, and various long-term complications occur because of various complex pathophysiology. So again, insulin resistance, if you see, because of insulin resistance, the fourth and fifth factor, that's what is discussed here, mitochondrial dysfunction, as I told you, there is increased reactive oxygen species. That's the most important thing. And with that, what happens is, white adipose tissue, with insulin resistance, it targets the skeletal muscles and targets the liver. To address insulin resistance, before going, so you want to address with a specific molecule, you should know whether the patient is specifically having a high index of insulin resistance, so that you choose the molecule. Precision medicine in diabetes, that is the key. Not that any patient coming with diabetes, you give OHAs of any choice. You should choose OHAs to target specific component of diabetes in a particular patient. That is what is precision medicine. Now, HOMA-IR is easy to calculate. We all know how to calculate. Hyperinsulinic hypoglycemic camp is a inpatient procedure which is not possible. TIG index is very important. TIG index, and there is a metabolic score for insulin. So TIG index and HOMA-IR definitely can be calculated, fasting insulin and lipid profile values. Definitely you can have an idea, and it will give a clear clue to the significant insulin resistance in any patient. So what is TIG index? Almost it is equivalent to insulin resistance. So what is TIG index is? What does it do is, see, you can see increased lipid oxidation, decreased glucose metabolism. It decreases the nitric oxide availability, increases mitochondrial reactive oxygen species. It causes thrombosis and inflammation. So diabetes is a CAD equivalent. That is why we say it can cause increased platelet hyperactivity, coagulation disorder, thrombosis, inflammation. The last is also in any diabetic patient. You can see if you do echo, there is a diastolic dysfunction. So now everything is normal, but there is a diastolic dysfunction. So it causes smooth muscle dysfunction because of glycosylation end product, smooth muscle proliferation or a collagen, which causes a cardiac fibrosis and ventricular stiffness. So don't underestimate a diastolic dysfunction in a diabetic patient. So with that, there is a decreased cardiac efficiency, myocardial cell death is increased, decreased angiogenesis, all contribute to cardiovascular disease. Why we are always now ADA 2026 specifically is target the organ dysfunction. That is why metformin is last choice of drug has been when there is a risk of or equivalent of cardiovascular or ASCVD risk in any patient, the molecule you are using for treating should be a different one, not metformin as the first choice. So TIG index, normal is, for a normal weight it is 8.46 plus or minus 0.61, overweight will be 8.93, obesity 9.05 is a significant. If it is high, you should always be careful. Always give a statin. If at all there is an increased ABCD risk, definitely give a single antiplatelet when there is a strong family history. So metabolic score for insulin resistance, it is calculated with 2 times fasting, blood glucose, triglyceride level into body mass index by serum HDL minus cholesterol level, that is non-HDL cholesterol, which gives a clear calculation of insulin resistance. Now, why this picture is, when there is increased GLT4 expression, there is upregulation of insulin receptor sensitivity. What happens is you increase the insulin sensitivity. So by this, what are the molecules which target various oxidative stress, target the liver, decrease inflammation, and take care of the pancreas and increase glucose uptake in the liver? That's what we are going to see the molecules. The first molecule, neglected molecule. I can always say it is a neglected molecule. Always it's better to use a low dose. I prefer 7.5, the maximum of 15. Everybody is worried about weight gain, but you should choose the patient who has to be given. If this is a very good molecule when there is a significant insulin resistance. With PPAR gamma activity, it has various support on anti-inflammation and lipid metabolism favorable for mitral. You can see what happens is it has effects on inflammation. It has effects on lipid, decreased lipid accumulation, increased insulin sensitivity, decreased glucose release, decreased cytokine production, and increased proliferative capacity of the liver. So that's a good thing. What we are seeing is MASLD, fatty liver, is on the increase. Some patients present with cirrhosis as the first presentation. So diabetes is organ. You should treat the organ, not the diabetes, not the sugars. That's what is the ADA specifically mentioned in this recommendation. I think I have 3 minutes. Okay, I'll finish it. So next molecule is metformin. Every time I say metformin should be in any patient with diabetes, irrespective of whatever it is. Unless and otherwise there is a contraindication to metformin. Contraindication will be a kidney disease with a specific creatinine rise, or they are prone for a GI upset. Some patients, rarely, recently we saw 2-3 patients with lactic acidosis, unexplained lactic acidosis. We stopped metformin, the patient improved. So if there is no contraindication, it's a very wonder molecule. You can see what are the benefits. It acts on insulin receptor sensitivity, PI3K as I told you, and AKT along with AS160, which are insulin signaling pathway. It is favorable for insulin signaling pathway. All the others are you can read from anywhere. So picture clearly says what are the pleiotropic benefits of metformin. So next is SGLT2. So I can say in my practice or anybody's practice, almost 70 to 80% of patients will be on SGLT2. SGLT2 should be there. Again, unless and otherwise, you have to choose the patient who should not receive. That's what you should know. Otherwise, you should use SGLT2 in any patient, unless and otherwise there is a prone for ketosis, whatever it is. We see very rare. You should educate the patient. Otherwise, SGLT2 will be a danger for the patient. You should educate the patient about perineal hygiene and other things. Definitely, the patient will have a very good effect. I am not going to all details. You can see. It acts on cellular stress, decreases cellular stress and apoptosis. It has modification of apoptosis and all others, hepatic insulin resistance. That is very important. As I told you, peripheral insulin resistance and hepatic insulin resistance, both are targeted and annihilated with SGLT2 inhibitors. The next molecule is GLP1. I will finish it. So 58 seconds is there. It's enough for me. So I am not going to detail. The second molecule, if at all, you should have in mind is apart from SGLT2, GLP1 will have. GLP1, SGLT2, metformin should be the ideal option for any patient, any naive patient, insulin naive patients coming to your clinic, unless and otherwise there is a contraindication. But always be careful, a GLP1 or DPP for whatever you want to use, there should be a component of 1 in 10,000 may develop a pancreatitis, very rare. We see pancreatitis in a few patients. So that's why I'm saying you have to educate the patient. It has various pleiotropic effects with triple agonist having, tirzepatide having other issues, other effects on weight loss also. So to summarize, what we should target in insulin resistance, we have discussed each molecule. What we should know is, what discussed also, you can see, when GLP1, what does it take care? Apart from various other issues, it takes care of the GI dysbiosis. It takes care of the gut microbiota. With that, there is, what happens if there is a dysbiosis? There is increased free fatty acid accumulation, white adipose tissue dysfunction with increased lipolysis. This is targeted by PPAR gamma, pioglitazone. That's what we have discussed. So various others. My talk was 20 minutes. That's why I prepared for 20 minutes. Anyway, it is for now. It is curtailed to 15 minutes. No issues. We have discussed enough. We will have questions. Any doubts will be cleared.
Thank you, Dr. Vengadakrishnan.